Good evening, everyone. Today's topic for our class is MRI in ophthalmology. I will be presenting the class, and the co-presenter is Asta. And the class will be moderated by Dr. Veena ma'am and Dr. KC sir. So this is the basic outline of our class. I will be discussing about the basics of MRI, and Asta will be discussing about the clinical findings on MRI. So as I have shown in the thing, magnetic resonance imaging is just MRI is based on absorption emission of the energy in the radio frequency range of electromagnetic spectrum. So the inherent electromagnetic activity of the atomic nuclei is being manipulated to manipulated so that we can produce a observable stimuli which can be captured and interpreted specific to certain tissues. So like the image shows, our proton, like our hydrogen atom has one proton, one electron. So it acts as a dipole, and the nucleus of hydrogen atom is essentially a single spinning proton, and this spin gives it an electromagnetic field, it will behave like a small bar magnet. In the native state, the tissues have no net magnetization since the hydrogen atom has one positive and one negative energy, and they are randomly aligned in the body. They have our body have numerous water molecules, and all have positive and negative energy gets cancelled by each other, so that we have a no net magnetization. So when we apply a external magnetic field, like shown in this image, the magnetic axis of the nuclei align with the magnetic axis of the external magnetic field B0, and the net magnetization of the tissue is hence formed, and this will be the key basis of the MRI. And after forming the net magnetization of the tissue, when there is a radio frequency wave which is applied to the steady state, so the nuclei will absorb the energy, and it will move from low energy state to high energy state. As we can see from the parallel configuration of the atomic nuclei, it gets changed. Yeah, it gets changed to the anti-parallel high energy state. So in this image, when there is no RF frequency applied, we could see only with the presence of external magnetic field, over half of the atomic nuclei getting aligned along the external magnetic field, whereas less than half of the atomic nuclei is aligned against the external magnetic field. So this image shows the precession of the atomic nuclei when it is rotating around its own axis, magnetic axis. This is known as the precession, and this is aligned along with the in phase when there is a radio frequency applied. So it was in phase. This is with the precession, and when the radio frequency is off, so we can see that the nuclei is out of phase. They are showing a different direction. They are actually pointing towards a different direction. So when the radio frequency is applied, the protons are tipped into horizontal or XY plane by an angle termed as the flip angle, depending on the type of radio frequency pulse. The rate at which the protons precess is termed as frequency, and the angular position of the precessing spin is called as phase of the spin. The frequency of precession is called as the Lamarck frequency, and it is characteristic of a specific nucleus and strength of the external magnetic field. The application of the radio frequency equal to the Lamarck frequency will provide energy that produces the realignment of the magnetic vector. This process is called as the excitation. So now I'm going to explain the T1 and T2 relaxation.
Hello. So in short, okay, if you want to explain how do you get an NMR signal, Okay, you basically, what do you mean by an external magnetic field? Basically, the magnet of the machine. Okay, what you have in the bore is basically a numerous coils which are wound round, which and you pass an electricity through that, so that acts like a magnet. So when you say an external magnetic field, it's basically the magnetic field which is there in the bore of the magnet. Okay, so you consider your body having numerous protons, and you place your body inside that bore of the magnet. Your protons will align parallel or anti-parallel, okay, and then they get nullified. So when you apply an RF pulse, okay, a radio frequency pulse, which is of the same frequency for the proton to resonate, okay, so you have, they align themselves in the Z direction, which is the direction of the external magnetic field. So when you apply an RF pulse, there are two things that happen. They move from the Z plane to the XY plane. Okay. And when you remove the RF pulse, they start going back into the to go back to their resting phase. Okay. That is a natural tendency of an excited proton to go back to the resting phase. So now we come to the T1 and T2 relaxation.
Yes, ma'am. So, so when the RF pulse is switched off, two processes takes place simultaneously. T1 and T2 relaxation takes place simultaneously. So here the Z vector, which shows the longitudinal magnetic plane, the recovery of the net moment in the Z axis, like this is the term as longitudinal relaxation. This is when the RF frequency is switched off from the excited state. The atomic nuclei returns back to this longitudinal direction. This is known as the longitudinal or T1 relaxation. It is the time required to build for the buildup of 63% of the original magnetization along the z-axis. So this is how it is. And once the initial 90-degree pulse is applied, it will go back to the excitation state. So after this, when there is like goes back to its original resting state, this the relaxation has been explained now. So the repetition time is when the another frequency is applied, and then it comes to the resting state.
So TR is the time to repeat, which means that from one RF pulse to the next RF pulse.
Yes, ma'am.
Okay, that is the time to repeat. Okay,
Yes.
then the next, what is the next? So basically, when you remove your RF pulse, there are two things that happen. The proton will try to go back to the Z axis. Okay, that is the field, the direction of the external magnetic field. And at the same time, it will try to dephase in the XY plane as well. Okay, so that is why it is called as a spin and spin lattice
Spin, yes, ma'am.
relaxation.
Yes, ma'am. So the nucleus, while returning to the ground state, dissipate their excess energy to the surrounding. That is known as spin lattice relaxation. And the smaller molecules reorient more rapidly than the larger molecules. And the medium-sized molecules also reorient faster than the larger molecules, such as a pure water or something like protein, so that they have a longer T1s. And yes, ma'am. So this is the T2 relaxation, spin relaxation. So it denotes the loss of phase coherence caused by interaction between the neighboring magnetic moment. So we could see that here. So after the RF pulse is been off, so right now it is not, we could see that there is going to be interaction between the neighboring magnetic moments here with the atomic nuclei. And we could see that there is going to be a loss of phase coherence, which could be seen here. And the T2 is the time required to reduce the transverse magnetization to 37% of its original value. So main contribution to T2 relaxation is from relatively a static magnetic field from the neighboring protons. Large molecules reorient more slowly than the smaller molecules. So there will be a more T2 relaxation and shorter T2 times.
The fat comes faster towards the z-axis, whereas water and takes is more towards the xy plane.
Yes, sir.
Correct.
Yes, sir.
So that's why fat gives a high value on T1.
T1. Yes.
Okay, because Z is represented by T1, isn't it?
No, it's not like that.
Ah.
Basically, every tissue in the body has got a T1 and T2 value.
Yes.
Okay, so based on their T1 and T2 value, you get the signal. So I told you to put it in the in a tabular column. Did where is
Yes,
the
ma'am.
normal tissues?
After this, ma'am.
Okay, then we'll go to that then.
Ma'am, I'll go to that slide or we can go ahead with this. Yes, ma'am. So the repetition time is between two RF excitation pulses, like ma'am explained before. And the longer repetition time will cause a more T1 relaxation to occur, and this property can be exploited to manipulate the contrast between tissues with different T1s or the signal to noise ratio in an image. And the echo time, the time from the center of the RF excitation pulse to the center of the echo is known as the echo time. And when the echo time is prolonged, the transverse magnetization becomes weaker, and adjusting the echo time influences the contrast between the tissues that have different T2s. Spin echo pulse sequence. This is one of the commonly used pulse sequences. So here, two RF pulses, that is 90-degree pulse and 180-degree pulse, are applied, spaced by a time interval of half of echo time. So after a 90-degree pulse, one or more 180-degree pulse is applied and followed by a echo, like that is the emission of the energy. So the time duration between that uh, after the nuclei excited by 90-degree pulse, the spin dephase in X and X dash and Y dash plane. This is followed by a refocusing 180-degree pulse. The faster spins lie behind the slower ones, but a time of half of echo time they may make up, and thus producing an echo. The 180-degree pulse results in reversal of the phase of each spin. So, like it is shown.
I think you can just touch upon the physics because you'll miss out on the
Important.
clinical part. So just let's just
the MRI hardware. So as we could see, this is how the MRI system appears like. So the magnetic strength of the diagnostic MR systems is 0.02 to 3 Tesla units, and the research systems can operate even above 3 Tesla, which we commonly use is 1.5 Tesla and 3 Tesla. 1.5 Tesla provides adequate diagnostic quality images, and whereas 3 Tesla provides a faster scan and better resolution. So here we could see a main magnetic field which is being produced by this, and then we also have the radio frequency coils over here, which is located along with the gradient coils. Okay. And then these are the transmitter and receiver coils, which is in contact with the patient side. So these are surface orbital coils, and this is used to obtain a better image quality of orbital MRI. Advantage is that it produces a better spatial resolution with thinner slices due to improved signal to noise ratio, and disadvantage is that it provides a limited depth of view up to mid orbital level. So this is the image showing the head coil and head and neck coil. So this is used for imaging the cranial anatomy, and head and neck coil can be used for MR angiography when we have to image the head and neck pathologies. So what is weighted? Weighted is when MRI sequence manipulates a magnetization and achieve the amplification or suppression of a particular tissue characteristic. Weighted is weighted to specific tissue characteristic. And what is the signal intensity? The appearance of the lesion, that is the brightness, can be iso intense, hypo intense, or hyper intense relative to normal reference structures, such as fluids such as CSF or vitreous, or soft tissue structures like extraocular muscle in that particular sequence. So this is the T1 weighted image. Like we could see the CSF, the vitreous.
Before you go to this, uh, identifying T1 and T2, how do you get a T1 and how do you get a T2 weighted image is basically by changing the TR and the TE. Okay, so that is the main basis of getting a T1 and T2. So, what is the TR and TE for a T1 weighted sequence, and what is the TR and TE for a T2 sequence? Okay, so for T1 weighted images, you use a long TR, sorry, a short TR and a short TE. And for a T2, you use a long TR and a long TE. Okay.
So, this is a T1 weighted image of the orbit and the brain, and like we could see the vitreous and the CSF is appearing dark in the image, and the gray matter is appearing darker when compared to the white matter, and we could see the CSF in the subarachnoid space and the ventricles appearing darker. And T1 hyperintense lesions are shown in this tabular column. The lipids and methemoglobin, proteinaceous contents, melanin, and mineralization would appear T1 hyperintense. So this is the T2 weighted axial T2 weighted image showing the orbit and the brain. So as the image shows, the vitreous and the CSF appears hyper intense, and the gray matter appears white, and the white matters appears grayish in the T2 weighted image. And so this is a difference between a T1 weighted image and T2 weighted image for normal structures. So the water appears darker in T1 weighted image and brighter in the T2 weighted image. Air appears dark in both, and bone and cortical bone appears very dark, and bone marrow appears bright in T1 weighted image, and it will have an intermediate intensity in T2 weighted image. Fat will appear bright in T1 weighted image, and it will have an intermediate intensity in T2 weighted image. Muscle appears dark in both T1 weighted, T2 weighted. CSF appears dark in T1 weighted image and brighter in T2 weighted image. White matter will appear bright in the T1 weighted, and the T2 weighted image will show a darker white matter, like what I have explained the previous slides only. So the blood can be differentiated into acute, chronic, hyperacute, and subacute based on the intensity in the MRI. So in the T1 weighted image, acute blood would appear as dark to intermediate, whereas the chronic infarcts would appear like a dark rim with variable center, and hyperacute would appear as intermediate intensity, and subacute hemorrhage would appear with a bright rim.
Why so? Why does the signal intensity of the blood change? Anyone? So it's basically related to the blood degradation products. Okay, from oxyhemoglobin to deoxyhemoglobin to methemoglobin to hemosiderin. Okay, hemosiderin is chronic and oxyhemoglobin is. So basically, the T1 and T2 are different. And that is why, as the blood products, as the hematoma or blood ages, the blood products will also keep changing. So why is subacute blood hyper? Because it's methemoglobin. So methemoglobin is a short T1 and that is why it is bright. Okay, so if all the signal is related basically to the T1 and T2.
Fluid attenuation inversion.
Blood is dark.
Huh?
Yeah, it will be ISO in T1 and then it will be, there's something called as a gradient sequence where we generally do for calcium and blood. So you'll get blooming on that particular sequence when it is at.
So FLAIR sequence is basically a T2 weighted image with suppression of signal from the fluid. So in this T2 weighted image, we could see that the fluids are not brighter. So the vitreous and the CSF does not look hyper intense. In turn, it looks hypo intense. Because of this, we would get a better detection and delineation of cerebral parenchymal abnormalities such as mast lesions, demyelinating plaques, or a perilesional edema. So confirmation, it's also useful in confirmation of presence of cystic changes. So this is how we can identify or differentiate between a T1 weighted, T2 weighted, and the FLAIR, we have to remember that in the T1 weighted image, the fluid is going to be dark, gray matter is gray, white matter is white. And in T2 weighted image, the fluid is white, gray matter is white, and white matter is gray. In FLAIR, it will same like a T2 weighted image, but just the fluid would appear darker. Yes, sir. Yes, sir. Diffusion weighted image, the property of random Brownian motion of water molecules within the tissue's interstitial space is being used in this sequence. The sequence acquisition consists of two parts, a B0 baseline image with only the external magnetic field applied, and a B1000 image which has an additional radio frequency pulse applied for 1000 milliseconds and tracks the motion of water hydrogen protons. Subtracting the image from these two acquisitions results in diffusion weighted image. So the map of degree of freedom of random movements of water molecule is obtained within the tissue. The region that allows a total unrestricted motion of molecule within a closed chamber, like in the eye and CSF in subarachnoid space or areas of cystic degeneration would appear hypointense. And when the motion has been restricted, then it would appear a hyperintense on diffusion weighted image. So diffusion restriction can be seen in abscesses in case of a cytotoxic edema, in highly cellular tumors, and in acute infarcts. In abscesses, mainly because of the infiltrates and the viscosity in the fluid in between, that would cause the diffusion restriction, which would appear as a hyperintense. Whereas the in the cytotoxic edema also, because of the fluid, the interstitial space is reduced, and because of that, there would be a diffusion restriction showing a hyperintensity. Same in the highly cellular tumors like lymphoma and in acute infarcts. This is the diffusion weighted image and apparent diffusion coefficient technique. In that, we calculate the apparent diffusion coefficient maps, and this usually shows a signal just opposite to diffusion weighted image. And this is used to quantify the degree of restriction, diffusion restriction, and also it is used in the prognostication. So this is showed as an average here. So this is the quantification of how much it is restricted. Pre and post contrast T1 fat saturated image. So here we use a contrast agent gadolinium, which is a paramagnetic substance which appears bright on T1. So these contrast agents distribute in the vascular and interstitial space, and which is in increased vascularity secondary to inflammation, in angiogenesis and altered homeostasis. So it does not cross the blood-brain barrier when the blood-brain barrier is intact. So normally there is no enhancement, but when it is disrupted, then the contrast will diffuse into interstitial space, producing the enhancement. And the optic nerve usually does not enhance. And this contrast should not be given to the renally compromised patients. That would cause the systemic nephrogenic fibrosis. And this can be used safely in children above 2 years of age. So this is a T1 fat saturated image. Yes. So this is post contrast. So here we could see the enhancement of the extraocular muscles of the scleral coat of the lacrimal gland. These are normally enhancing lesions when the contrast is given.
Basically, both are contrast enhanced images.
Yes.
But by suppressing the orbital fat, you can see if there is any enhancement in the optic nerve or any tumor that is present in the orbit. Okay, the the lacrimal gland and extraocular muscles enhancement is normal.
Yes.
Okay, these are the only extraocular muscles in the body that, I mean, the only muscle in the body that enhances. Other muscles do not enhance post contrast. So by suppressing the fat, you basically want to look for any enhancement that is there in the pathological tissue. Okay, so you can see the difference between the left and the right.
Yes.
Okay, if you have a lesion which has picked up gadolinium and it is as bright as the orbital fat, you will not see the
Yes.
lesion as at all.
Yes.
So it's very important that post-contrast study should always be a fat-suppressed T1 sequence. Okay.
Yes, sir. So sclera, choroid, and retina, lacrimal gland, extraocular muscle. Yes, sir. Three. So enhancement can be differentiated, like has these three characteristic of homogeneity, intensity, and pattern. So it can be homogeneous and heterogeneous. Intensity can be hyper-intense, iso-intense, and hypo-intense. Pattern can be enhancing and non-enhancing. So enhancing non-enhancing lesions are lipomas, lymphangiomas, benign cystic lesions, because these are poorly vascular. Ring enhancement can be seen in neurocysticercosis and abscesses, and non-enhancing with non-enhancement within enhancing lesions can be seen in necrosis and cystic areas, and gradually increasing in the serial sequences can be seen in hemangiomas. Yes, sir. Later it will be explained. In clinical findings, it will be explained. So other sequences which we use is short tau inversion recovery. It is mainly used in imaging the optic nerves. It suppresses the orbital fat and highlights the lesion within the optic nerve, mainly in optic neuritis. And other sequence is Fiesta. It's a fast imaging employing steady state acquisition sequences. It provides the image of fluid-filled structures with short acquisition times. So the Fiesta sequence uses the T2 steady state contrast mechanism to provide a high SNR images with strong signals from fluid tissues while suppressing the background tissue for a contrast and anatomical details of small structures. And Fiesta C or Cis Fiesta, it is a constructive interference in steady state. Steady state. These are like new sequences. It's currently is a sequence of choice in CSF cysternography for visualizing the cranial nerves of the skull beak.
So basically, their application in ophthal, okay, stir is basically for the optic nerves. So when you have a patient of optic neuritis, generally we do the stir sequence. Okay, Fiesta is done for hemifacial spasms. Okay, so that gives you the cisternal segment of the cranial nerves, and therefore any vascular conflict that is there on the seventh nerve is easily visualized on the Fiesta sequence. So, if you want to image the cranial nerve, that is only the subarachnoid course of the cranial nerve because it is surrounded by fluid. Okay, so the nerves stand out against a bright fluid, and therefore you can just pick up if there is any pathology along the cranial nerves. So in ophthal, we basically use this primarily for hemifacial spasms to pick up the neurovascular conflict and for other cranial nerves to just see the subarachnoid course of the cranial nerve.
So, interpretation of MRI. So, when we are given MRI film, basically we see the left side for the patient's details, and the identification of left or right would be based on this LPH. So, that is usually the left side. The other side is the right side, and imaging plane can be a axial plane, coronal plane, or a sagittal plane. And sequences we just uh, explain the different sequences which is being used, and the slice thickness would differ, and the contrast is whether used or not we have to see, and if the contrast is used we see whether it is enhancing or not. So this is the axial view, the coronal MRI view, and this is the sagittal view. So MRI versus CT. So basic difference that we find when there is a CT or MRI is given that the bone appears bright, whereas in MRI it appears darker. We should not get confused with this outer line, which we could see in the MRI. That is nothing but the scalp fat tissue that appears brighter in the MRI. And the advantage of the MRI would be it doesn't have exposure of ionizing radiation, and it has excellent soft tissue resolution. Entire optic nerve is imaged without any bony shadow interference. Age of hematoma bone marrow lesions show a better resolution, and it uses a safer contrast agent if it is required. So CT has is very advantageous in bony pathologies, fractures, and calcification in tumor masses. It is indicated in case of intraocular foreign bodies, and it is ideal for unstable patients as the test duration is very short. The disadvantage would be it's more expensive. MRI is expensive and it's difficult for unstable patients who cannot lie for a longer time. For obese patient and claustrophobic patient, it's contraindicated with a ferromagnetic intraocular foreign body. And air and bone both gives the picture of a signal void, hence difficult to interpret and not suitable for bony lesions and fractures. The disadvantage of CT would be exposure of ionizing radiation. It's lesser sensitive than MRI in imaging the intracanalicular and intracranial optic nerve and cavernous sinus and diseases of white matter such as disseminated sclerosis. Contraindication, absolute contraindication, ocular orbital absolute contraindications are ocular, orbital, and intracranial metallic foreign body, cardiac pacemakers, or any device which generates electromagnetic field for its function, magnetic intracranial aneurysm clips, which is of older models, and cochlear implants. Relative contraindications are orbital floor implants, titanium mesh, eyelid gold weight implants, presence of calcification of and obese patients, it's difficult to perform. Claustrophobic patients, it is difficult, again, it's difficult to perform.
I told you yesterday,
Yes.
orbital floor implants are not a contraindication to do an MRI. It's not a relative contraindication also.
Okay.
We do image orbits with titanium implants.
So, appearance of normal ocular structures and different in T1 in sequences. So, in a T1 image would show a hyper intensity in sclera, choroid, and retina, whereas in T2 image would show a hypointensity. Aqueous humor would appear hyperintense in T2 image and hypointense in T1 image, and lens would appear hypointense. I mean, it will appear intermediate, whereas in T1 image it appears hyperintense. Vitreous humor would appear hypointense, whereas in T2 image it will appear hyperintense. Extraocular muscles would appear intermediate intensity in both T1 and T2, and orbital fat appears hyperintense in T1, and in T2 image it appears intermediate hyper intensity. Optic nerve would appear same as isointense when compared to the cerebral gray matter, and it shows no enhancement normally. And optic nerve sheath with
1 minute. Optic nerve is not isointense to the cerebral gray matter. Optic nerve is a white matter tract.
Yes.
So it is isointense to the white matter, not to the gray matter.
And the lacrimal gland appears isointense, and bone will appear as a signal void, it will appear as a black intensity, and CSA would appear hyperintense in T2 and hypointense in T1. So this is the axial MRI at the level of inferior recti. So axial MRI, we see in the different level from the inferior orbit and through the level of the globe and to the superior orbit. So this is at the level of inferior recti. Uh, so this is the T1 weighted image. As we could see that CSF and the vitreous is darker, and normal structures which we could see here is the nasolacrimal duct, which we could see, and we could see inferior ophthalmic vein, and we could see the ethmoid sinus and sphenoid sinus, and we could see the temporal lobe, and we could see a greater ring of sphenoid in both, and temporalis muscles which we could see here. And at the level of eye globe, that is in the midsection, this is the T1 weighted image, T2 image, weighted image, like we could make out from the difference in the CSF and the gray matter. So, so this is the orbital septum. This is the anterior chamber lens, which we could see, ciliary body, this lacrimal gland, and this is choroid and retina, and this is the vitreous cavity, optic nerve, which we could see here. This is the medial rectus. This is ophthalmic artery. This is lateral rectus. This temporalis muscle, greater wing of sphenoid. And this is the temporal row in this internal carotid artery. This is the optic chiasm, which we could see here. Low white, sir.
Low wide, yeah.
Yes, sir.
Low wide.
So this is at the superior section.
The flow void on T1 and T2 are dark.
Yes, sir. Yes. So this is at the level of superior ophthalmic vein. Again, this is the T2 and T1, T2 image. So here we could see the frontal sinus, ethmoid sinus, superior ophthalmic vein, which we could see, lacrimal gland we could see, and the greater wing of sphenoid, superior rectus we could see, and temporalis muscle, temporal lobe, like what we have shown before. So coronal MRI, again, there is going to be a section.
Sorry, can you just go back?
So this is the anterior section at the level of eye globe. So this is the eye globe, medial rectus that we could see, ethmoidal sinus, superior oblique muscles, LPS muscle, lacrimal gland, and the superior rectus we could see. And this is the inferior oblique, inferior rectus we could see. This is a maxillary sinus. The level of midsection is again the T1 image and T2 image. Again, this is the LPS muscle which we could see, and the frontal lobe, ethmoidal sinus which we could see here, and this is medial rectus, and the superior oblique muscle, LPS, superior rectus muscle, and superior ophthalmic vein, optic nerve which we could see here, and the lateral rectus, medial rectus, inferior rectus, and inferior ophthalmic vein. So this is the posterior most section. Here we are not able to see the globe, and here we could see the sphenoid sinus, middle cerebral artery, temporal lobe, optic nerve which we could see, and
Which part of the optic nerve is in relation to the sphenoid sinus?
intracranial.
Hmm?
Intracranial.
Cranial. Intracranial is surrounded by CSF, no?
Intracanalicular part.
Yeah, so now tell me, where is the nerve? Just keep the cursor. Where? Can you bring the pointer here?
Yes, ma'am.
So this is your intracanalicular optic nerve. Okay, can you see this paired structure on either side? And this is the boundary of the optic canal. Okay, so what you're seeing here is the anterior clinoid process. Then you see the optic tract here, and medial is the sphenoid sinus. Okay, the very important section for traumatic optic neuropathy. Okay, for CT as well as for MR.
So this is the sagittal MRI. In its oblique section in parallel with the optic nerve sheath complex. So again, these are the normal structures which we could say in this kind of section. So this is the anterior chamber, vitreous cavity, optic nerve, anterior clinoid process, LPS muscle, and the orbital septum, which we could see here. This is the maxillary sinus, and this internal carotid artery. This is the temporal lobe, and superior rectus muscle from here, inferior rectus muscle, and superior ophthalmic. So these are my references.